Welcome, everyone. Thank you so much for joining today's symposium on COVID-19 vaccines, unfinished business. Our topic today is improving immunization coverage, messaging, and communication, and our moderator for today will be Dr. Philip LaRussa. Dr. LaRussa is a pediatric infectious disease specialist with 4 decades of experience in clinical and epidemiological infectious disease research in local and global settings. He is Emeritus Professor of Pediatrics and the Special Lecturer in Pediatrics at the Columbia University School of Medicine. Over the last 10 years, Dr. LaRussa has also focused on capacity assessment and capacity building research projects in sub-Saharan Africa, and it is my pleasure to hand over to him to begin today's session. Thank you very much.
Thank you, Harlow. Welcome to day 2 of Columbia University's Symposium on COVID vaccines, unfinished business. I just want to briefly go over what we heard in yesterday's session because I think it's relevant for some of the topics that we'll be discussing today. So yesterday's session focused on themes of where the science is leading us, the state of the epidemic, and current and future challenges. And I'm just going to make a few comments about what some of these speakers said, because I think they're relevant. Sir Jeremy Farrar discussed the utility of and some of the issues that will come with additional booster doses of vaccine, and made the comment that you can't vaccinate the entire world every 3 months, which is relevant to our discussion of the changing science. Dr. Kate O'Brien made the point that the best vaccine in the world is useless unless you can get it into people's arms, which obviously is pertinent to today's discussion. The speakers also discussed the improving situation with the availability of vaccines and some of the ongoing problems with equitable distribution of those vaccines. We also heard about wide variation in trust and acceptance of vaccines when they are available, and this variation was not only by country, but within regions of countries. And I'll just comment, yesterday I took a look at our City of New York's website, and only 58% of children 5 to 17 are fully vaccinated. And this is a little bit slower than we had been hoping for. And while 87% of adults are fully vaccinated, only 44% have received an additional dose. And if you look at adults over 65 years of age, only 56% have received an additional dose. So we have a lot of work still to do. So today's session will address themes of improving coverage with COVID vaccines, and improving messaging and communication, and the role of vaccine safety science in increasing trust. Unfortunately, our first speaker, Dr. John Kengasong, who's the director of the Africa CDC, cannot join us today, but Dr. Raji Tajudeen, who's also at the African CDC, will join us for the panel discussion, and I will introduce him later. What we'll do is we'll have our two speakers, Dr. Tom Frieden and Dr. Dan Salmon, give their presentations. I'll make some comments, and then we'll have a panel discussion with our 2 speakers, myself, Dr. Tajudeen, and I've also asked Dr. Wilmot James to join the panel discussion. So our first speaker is Dr. Tom Frieden. He's currently president and CEO of Resolve to Save Lives. He's a former director of the U.S. Centers for Disease Control and Prevention and former commissioner of health of New York City. He's also a senior fellow for global health at the Council of Foreign Relations. And importantly, he received his Doctor of Medicine and Master's of Public Health degree from Columbia University. His presentation today will be on how do we improve messaging and communication with the goals of increasing trust and confidence in science and public health initiatives. Thank you, Dr. Frieden.
Thank you, and it's a pleasure to be with you all. It's a very important topic, and I'll get right into the issue here on messaging and communication. Trust is essential. And trust is one thing that you cannot surge during an emergency. If it's not there before, it's going to take time to build. But trust is very important that we build as we are moving forward to increase vaccination and to address the many lessons that COVID has taught about public health and the weakness of public health. I think I go back to some basic principles. Impact matters, not intent. So we have lots of well-intentioned programs that don't make an impact. We want programs that will save people's lives, programs that will protect people from infection, programs that will allow societies to keep moving forward economically, educationally, socially without disruption. Technical excellence is absolutely crucial for program design. Time is lives. The amount of time we spend results in, has an immediate implication of whether or not we can make a big difference. And effective management can make an enormous difference. Finally, we like to say, oh, let's keep it all non-political. Public health decisions are political decisions. They shouldn't be partisan decisions, but they're political decisions, and they may, in fact, may be a totally reasonable approach that gives a different answer in different communities. But in all communities, we work to maximize and optimize health. There are lots of ways not to communicate about science, and there are some ways that are better to communicate. Better not to talk like a scientist, better not to use jargon, but not to dumb things down. Keep things simple, but not too simple, not simplistic. Tell a story with data. Ensure that the communication resonates with the audience that you're speaking with. Use plain language, limit to 3 or 5 key points with just a phrase of each. Use visuals wherever possible, as this slide beautifully demonstrates. Describe the situation, what specifically people can do. This is really important. If you don't give people appropriate things to do, they will do inappropriate things if they're anxious and want to do something. Simple is better, simplistic is not. Enlist and work with knowledgeable media people. Now, the narratives are very, very important, and statistics can give you an analysis, but a story gives you a potential of change. I thought this slide was a little ironic, since it says that stories are 22 times more memorable than facts or figures alone. So I'm not sure that 22 times is important there. It kind of belies the message, but it is an important point. People are convinced by narratives. That doesn't mean that we're playing fast and loose with the data. That means that we understand what it takes to change behavior. And for most people, that isn't statistics, it's a story. And that's the case for lots of health education, lots of messaging. There are many different contexts within which behavior change and decisions are made: individual, interpersonal, institutional, community, and policy. And these affect one another. Risk communication best practices from the CDC hasn't exactly been implemented by the CDC in this pandemic, but they literally wrote the book on this: be first, be right, be credible. It has to be done well to be effective. Information is easily understood and communicated if there are trusted and accepted channels. And really the principles of empathizing, under-promising and over-delivering, being frank about the uncertainty of the situation, being forthright about the process to fix the problem, addressing safety concerns, and countering rumors and myths in real time are all quite important. Trust is lost in buckets and built in drops. And unfortunately, our public health institutions will be building for some time. When we think about concerns, there are different concerns among different people. And that means that we have to personalize or individualize or be specific to different communities to address intent to vaccinate. Targeted messages increase the intent to vaccinate much more than non-targeted or generic messages. The most common concern among unvaccinated is the perceived health risk of the vaccines. In addition, the lack of perceived risk of the virus. And this is true across multiple countries where we and others have done polling. Message needs to be modified as the pandemic evolves. The virus and the pandemic are evolving. The only constant is change, and therefore we have to adapt our communication approaches as the virus evolves, updating to address variants, vaccine efficacy, children's vaccination, and other issues. Some messengers are more trusted than others. Healthcare workers are absolutely essential. Friends and family members, also very important. However, vaccine hesitancy is pretty high among healthcare workers, and therefore in areas of the world where vaccination is low, getting healthcare workers vaccinated is extremely important. Vaccine communication efforts need to address hesitancy among healthcare workers. Social norms are also very powerful. People surround themselves with like-minded individuals, and an individual's vaccine beliefs are often closely aligned with the beliefs of their social networks. Within social networks, with a low intent to vaccinate, identifying messengers who can communicate about vaccine benefits, the harms of the disease, and address vaccine concerns can be effective. But this really depends on country ownership of vaccine initiatives supported by local stakeholders. One of the projects that we at Resolve to Save Lives have worked on over the past 2 years has been a public-private partnership with the Africa CDC and others that supports evidence-based measures to reduce the impact of COVID in Africa. We've collected population surveys and social, economic, and epidemiologic and movement and security data to help determine the acceptability, impact, and effectiveness of public health and social measures and of vaccine acceptance. And the results are quite striking. In September 2021, 78% of survey respondents reported relatively high levels of vaccine acceptance. That was defined as either having already received at least one dose or planning to get vaccinated. That was up not insubstantially from 67% earlier in the year. So an increase, but remarkably, look at the graph here at the variability from vaccine acceptance of 97% in Morocco down to 43% in Cameroon, a really big difference. 20% of respondents said they weren't going to get vaccinated and didn't intend to. That range from 2% in Morocco to 52% in Cameroon. So really big differences among areas. Acceptance rates were influenced by trust, again, in key people and institutions and their handling of the pandemic, perceived risk of COVID, age, trust in vaccines, and the availability of vaccines. The reasons for vaccine hesitancy: I'm not at risk, I don't know enough about the vaccine, I don't trust, the vaccine is killing people, I'm afraid of injections. The key mediators of vaccine uptake include more information on vaccine, how it works, whether it's safe, from health workers, from radio, from religious leaders. Information needs to be disseminated through trusted people and institutions. Almost 3 out of 5 respondents reported trusting COVID information disseminated by religious leaders, so that may be an additional strategy that can be used. There are inadequate surveillance systems, and this undermines people's understanding of the epidemiologic context. The public may only know about reported cases and deaths, but this may be a small fraction of the actual burden, and that may lead to an underestimation in the public's mind of the risk of COVID. Different populations in different countries perceive the risk differently. In South Africa, with a large recorded number of cases, 43% of respondents reported a belief that their personal risk was high. In Sudan, only 26% reported that, despite evidence of a severe outbreak in that country. There is an organized and growing global anti-vaccination industry, and I use the word industry advisedly. It communicates through social media networks. Some of the anti-vaxxers really are economically motivated. They're making money on this. Some are true believers. Both use COVID as an opportunity to drive long-term vaccine hesitancy. And if you think about it, the conflict is asymmetrical. Health professionals, public health people need to convince people to take an action. Anti-vaxxers only need to encourage inaction by casting doubt on vaccine efficacy, safety, or necessity. It's a lot easier to convince someone to keep not doing something than to do something. Deliberate spread of misinformation and disinformation can be deadly. It's often done by unknown actors using social media, provocative, inflammatory. The primary purpose is to polarize and disrupt, sometimes for specific political or social reasons, sometimes disruption for its own sake, often outsourced to third-party companies in low and middle income countries. Healthcare workers are critical partners here, yet vaccination rates remain low. They're essential to maintain essential health services. They're highly vulnerable to COVID. Many are vaccine hesitant, and that's a key barrier. They're also ideal champions. They're widely trusted by the public, who see them as a source of reliable information. So addressing vaccine hesitancy among healthcare workers has knock-on effects that can be very positive. There was a CSIS London School panel that had some recommendations for increasing vaccine confidence in the US worth mentioning. Innovate to reach different populations, address mainstream and digital platforms, increase engagement by key social and economic sectors. Now, often in these talks, we talk about lessons learned. I've changed a little bit to lessons which we need to learn. First, to meet people where they are, physically and in terms of messaging and values communication. Understand who the trusted messengers are and deploy them. Invest in educating, vaccinating, and building healthcare worker confidence. Strengthen public health data systems, especially surveillance. Understand timing. It takes time for people to see and understand the value of vaccines. Take a comprehensive and preventive approach to disinformation, including rapid detection, rapid response, and root cause analysis of the different platforms and actors so that preventive strategies can be addressed. We need to address misinformation as an infection, rapid detection, rapid response, and effective prevention. 50 years ago, John Duffy, who wrote a history of public health in New York, wrote, "Encountering apathy, ignorance, and avarice is the lot of all conscientious health officers. As preventive measures in the health area are more successful, the public is less inclined to support the programs which ensure this success." A rather depressing point, but a fact that the more a problem is out of control, the more willingness there is to address it. The more it's in control, the less the willingness to address it. So I'll stop there and look forward to the conversation.
Thank you, Dr. Frieden. We'll certainly be coming back to some of the points you raised in your presentation during the discussion. Our next speaker is Dan Salmon, who's a professor at Johns Hopkins University, Bloomberg School of Public Health. Dr. Salmon received his MPH from Emory University and his PhD from Johns Hopkins. His primary research is focused on optimizing the prevention of childhood infectious diseases through the use of vaccines. And his presentation today is entitled "The Role of Vaccine Safety Science to Ensure Trust, Confidence, and Vaccines Acceptance." Dan, we look forward to your comments. Dan, are you on mute?
There we go. Can you hear me now?
Yes.
I mean, my presentation is up, I think. So I apologize. I'm having all sorts of technical issues here. So I'm going to talk about the role of science and science on safety underlying trust and confidence. And the two are so fundamentally linked. At the end of the day, what people want to know is that the benefits are greater than the risks. And the big caveat here is for people like me, right? Or for my child, because we in public health are interested in looking at this broadly for the impact of a vaccine program, but people are making individual decisions and they want to know if there's a problem that they're going to know, that if something comes up, they're going to be aware. And the point I'm really going to try to make in the time I have is that what we need is rigor, speed, and trustworthiness. And that's what it all really comes down to from a science perspective. So, our process for licensing vaccines or authorizing vaccines ensures that the benefits are greater than the risk for the populations and the outcomes studied, right? And we have a really good history of that. We don't have vaccines that have been routinely recommended in the US where this hasn't been the case. And this is based on clinical trials, which are the gold standard, right? Randomized, blinded. It really reduces confounding and bias. It allows us to make causal inferences that we couldn't through other means. And with these strengths come limitations, right? We can't study things that are among people that were excluded in the trials or inadequately powered, things that are delayed or things that are rare. Here's a really nice slide from Susan Ellenberg. This is more than 20 years old, but she looks at, okay, the size of the trials we do for something that happened 1 in 1,000 times. If we wanted to detect a doubling to 2 in 1,000, we need 50,000 people, which is a huge sample size. We came close to it with COVID. But if you missed this and you went ahead and vaccinated all the adults, this is with 1 dose of 1 vaccine, you would impact 200,000 people. So it really emphasizes the large impact that even something rare in vaccine safety can have. And that's what we rely on for observational studies, right? Post-licensure or post-authorization to look at things that are uncommon or in subpopulations. And remember, it's these subpopulations that are, is it safe for people like me or my child that matter? And it's really large healthcare databases and infrastructure that lets us develop this science. And we know there could be adverse events following immunization that are caused by vaccines. 1976 and Guillain-Barré is an example. And then these spurious associations. And, fundamentally, bad things happen every day. So if we vaccinate a lot of people today, every bad thing that happens tomorrow happens after vaccination. And this is a human fallacy, right? We presume because one thing happened after another that it must be causal, but that's often not the case. So what do we need in the science? We need to distinguish between real problems, which can happen, right? No vaccine is perfectly safe, coincidental associations, and we need to do this quickly. And it needs to be rigorous, and people have to believe it. So for passive surveillance, these are signal detections. We have a system where pretty much anybody can report anything. And this is what much of the world relies on. There's lots of great things about it. It gives people a place to report. You can detect signals. It suffers from underreporting and incomplete reporting. And in most cases, you don't know if what you're seeing is that background rate that would have occurred anyway, or more than expected. And to evaluate this, we tend to use large databases. The Vaccine Safety Data Link has been around not more than 30 years. And it's a comprehensive inpatient, outpatient, and you can do really rigorous studies through the VSD. So I'm going to talk a little bit about things that worked and things that didn't work, and again try to highlight speed and rigor and credibility. So if you look at the Qatar incident, this was the launch of the polio vaccine, and it was a huge time in American history, right? The developers of those vaccines were on Time magazine, and shortly thereafter there was reports of paralysis following vaccination, and CDC had just established the EIS and did a rapid investigation, and they found that primarily one of the labs, Qatar Laboratories, wasn't fully inactivating the vaccine, and it was actually causing wild disease. The vaccine program was halted for a matter of days, but because of this rapid investigation and robust, rigorous science, because people believed it, the program continued. And we're very close to eradicating polio today. So I think, to me, this is a great example of where rapid response, quick action, and ultimately many lessons were learned from this that impact what FDA does today. There's a lot of examples of what didn't work. I mean, I think autism is a great example. And this was a systematic review that we conducted. And, there's 16 well-controlled studies that show that MMR vaccine and thimerosal vaccines and multiple vaccines don't cause autism. All 16 of them were negative studies done in different populations using different methods, published in great journals. And people will look at this and say, well, the science doesn't matter, right? It's overwhelming that vaccines aren't associated with autism, yet somewhere around a quarter of people still in the US at least report that being the case. But here you look at these studies over time, right? So this issue arose with Wakefield publishing a paper later retracted in the Lancet in February of 1998. It took 18 months for the first study to come out refuting that what was called a case series, and years before there was US data. During that time, you had a charismatic, well-credentialed scientist, doctor traveling the world saying, I've shown vaccines cause autism. So that 18 months was it was too long. If you look at thimerosal that rose in 1999 in July, it took years before we had epidemiological data. So the science was done, but it was done slowly. We can look at what was done for safety surveillance for H1N1. And if, I'm sure everyone remembers the controversies at the time around the vaccine and the idea that it might have been a hoax. We saw a new president, a new administration, getting vaccinated. And there were all these challenges, right? How do you link exposure, who got the vaccine, with outcomes? Because it was a mass vaccination program, not unlike COVID vaccines. And there were lots of uncertainties. What type of vaccine, how many doses, how would it be available? At the time, we got recommendations from the National Vaccine Advisory Committee suggesting we do 5 things. We look at the background rates of health events, right? Knowing these things will happen by chance alone, to develop and disseminate a plan. What is the government going to do to monitor safety, and how will all assets be used? They recommended more active surveillance, right, for this rapid, rigorous science to figure out coincidental from causal, a transparent, independent review, and then lastly, to develop and test plans in advance. And I'm just going to walk you through these because I think this shows an approach that accomplishes what's needed for speed, for rigor, and for trustworthiness. This was a paper we published in the Lancet well before the vaccine program started. And we looked at a whole bunch of different outcomes measured in different ways in different populations. And the point being that these things happen all the time. And a vaccine program has to anticipate that. And when they do occur, we can't jump on the anecdote, the power of the story, and presume that it's causal. We had federal plans. This was put together across all of HHS, including NIH and FDA and CDC and HRSA, Indian Health Services, but also Departments of Defense and Veterans Affairs. It was through a coordinated federal effort. It was made available publicly and to partners well in advance of the safety monitoring program. And we held tabletop exercises where we brought in HHS leadership and Dr. Frieden, for example, and walked through what happened and how things might unfold, and to see what questions we got from reporters. And we walked through scenarios like, there's several cases of Guillain-Barré. What questions will you ask us? And then we showed them that Lancet paper and we said, we know these things will happen. And I think this helped prepare us, but also the media, for what was going to come. This is what the surveillance systems looked like prior to the launch of H1N1. And for testing hypotheses, the vaccine safety data link, really what had been the framework of our safety monitoring. We also had data from Veterans Affairs, from DOD, and then CMS, which was a really large database, primarily of the elderly. But if you look at the size of that for the elderly, it's really large, which is great. We added a new system. We quickly linked state immunization information systems or registries with large health insurance companies. And this allowed us to put a very large number of people under active surveillance. And when I say active surveillance, I mean that from an epidemiological standpoint. It was all de-identified and private. And if you look at where these data came in, and it's really the total H1N1 doses captured that drives your power, you see CMS for the elderly was really, really helpful. And then this new system, PRISM, and the VSD with the rest of our data, right? So we had a lot of data. It was being reviewed regularly. And this is from a report that I'll share with you a bit more details in a minute. The first line is VAERS. So this covers pretty much everyone who got a vaccine, right, can report to it. But it shows you how each of these databases contributed to our knowledge. And perhaps most importantly, within 6 months of the vaccine rollout, we had a tremendous amount of data from across the US population, special populations, but also subpopulations like children. And through this, it was reviewed independently. And the recommendation was for a group that was focused entirely on risk assessment. So, this is an important principle that came out of the 76 swine flu affair. And it's widely recognized in many, many arenas, from transportation safety to, space shuttle travel. The assessment of safety needs to be independent from the management of those risks. And this committee was set up purely to look at the safety of the vaccines, leaving the risk management to ACIP and CDC. So their goal was to characterize the safety based on a huge amount of data. In the end, there were early signals for ITP and Bell's palsy. It turned out there were no associations. In the end, it was spurious, and a very small risk of Guillain-Barré. And I can show you just a bit about what that data looked like from each of the systems, and then finally a meta-analysis. So we saw about a doubling of risk, translating into 1 to 3 cases of Guillain-Barré per million people vaccinated. Very, very small risk. And this, in fact, was reported publicly. Every 2 weeks, the group met. Once a month, it was deliberated upon publicly at the NVAC. And there was, a little bit of media coverage, but nothing more than to be expected. Transitioning now to COVID, right? I think the challenges for COVID safety monitoring were just a lot harder. For one, we had far less experience with the technologies. With H1N1, we had decades of use of flu vaccines. We knew those vaccines really well. And we didn't have that for COVID, right? They were newer products. We needed to know who got what product, like with H1N1, a mass vaccination program. And when there's multiple products, I showed you a lot about size of databases. Well, you got to start dividing it by who got what different vaccine. And then the potential for coincidental events. I mean, there was this wide perception that the vaccine was rushed. And we're living in a world of alternative facts. And I'm sure no one needs reemphasis on how far-ranging they can be. So we had Operation Warp Speed, right? And their goal was to make sure every American had a vaccine available to them within a year. And in fact, that goal was met, which is with very safe and very effective vaccines. This is a slide by Dr. Sarah Oliver at ACIP prior to vaccine rollout, and it shows vaccine intentions over time prior to rollout. So, that is not a climate in which one wants to roll out vaccines. Specifically, a substantial proportion aren't intending to get it. And the presumption was that if we build it, they'll come. And that may have been true for polio, but certainly not for COVID vaccines. So what was done for safety monitoring? It was a CDC-led effort. It continues to be. The Advisory Committee for Immunization Practices is the public-facing. We have data from VAERS, from vSafe, which is a new system using text messaging tracking, the VSD, which we've talked about, and then this new system from FDA called BEST, working with CMS. And that's where the data has come from. What we've seen is a pretty strong association with TTS and Guillain-Barré following the J&J vaccines. And, these are kind of unusual situations, right? Because typically, as I pointed out, a system like VAERS that's passive, you can't establish causality or know rates. But, TTS was doesn't really happen clinically presenting absent vaccination. So it's kind of an exception, almost like vaccine-associated paralytic polio, where you can look at cases and know there's a high probability that it's caused by the vaccine. We now have a preferential recommendation for mRNA vaccines, and we've seen an association with myocarditis. The first data came out of Israel. What we've seen out of the Vaccine Safety Data Link is a risk of about 1 in every 5 to 12,000 younger males after the second dose. And that risk is much lower among females. And as people get older, it seems to be higher for Moderna than Pfizer. And we're really wrapping our systems around these data to see, what that risk really is and among whom. So, I would ask the question, and I won't try to answer it, but, was the vaccine safety monitoring program sufficient for COVID? Did it meet these qualities of rigor, speed, and trustworthy? And let me end there. I'm happy to join a discussion later.
Thank you, Dan. We'll go back to some of these issues, but that was a very complete review of the country's safety monitoring program. I can say I've been involved with the CDC's Clinical Immunization Safety Assessment Center since the early 2000s, but we focus on individual cases trying to establish causality and management after adverse events temporally associated with vaccines, which is, I think, very helpful to the individuals involved, but not so impactful on the level that we hope that some of the efforts that you've made can impact the population. So we're now going to go to Dr. Raji Tajudeen, who has graciously agreed to step in for Dr. Nkengasong. Dr. Tajudeen is head of public health institutes and research at the Africa Center for Disease Control and Prevention. He heads the Healthcare Preparedness and Countermeasures section of the Africa CDC COVID response. And along with Dr. Stanbury and James in our group, is a member of the Vaccine Safety and Confidence Building Working Group. And he's agreed to make a few opening remarks before we go on to the panel discussion. Dr. Tajudeen.
Thank you so much, Philip, and thank you for the invitation to be part of this. Again, I convey John's apology. He will have actually loved to be here. So let me say that at the middle of last year, just before the COVID-19 vaccine was given emergency use authorization, as Africa CDC, we do put in place a strategic document for COVID-19 development and access. And under that, a couple of activities there. But the one that key into what we are discussing here today is about the issue of access and removing barriers and making this vaccine accessible to everybody. Fast forward, we have seen what has played out in terms of equitable access to COVID-19 vaccines. I mean, some of the previous speakers have actually alluded to that. So today is what it is. As a continent, we have been able to come up with a complementary mechanism to what has been put in place by the global players or the multilateral mechanism. So today we have what we call the AVAT, the African Vaccine Action Task Team, through which we have been able to make 400 million doses of vaccines available to our continent. Today, we have been able to launch what we call Saving Life and Livelihood Program. And underneath this is a partnership to accelerate COVID-19 vaccines in Africa. And you will agree with me again that today we are far behind as a continent. We are left with what is trickling down, and we are actually at the back of the queue. Today, as a population of 1.3 billion people, we have been able to vaccinate only 15% of our population. And going by WHO target of 70% by year 2022, we are supposed to vaccinate 900 million people. The 15% we have been able to do is just 200 million. So meaning that we have 700 million to go. And just last month, early last month, when our head of state and government met, this issue was raised and it was quite concerning to them. And they actually tasked us as Africa CDC, the African Union, to work with all the partners and come up with innovative way of accelerating this COVID-19 vaccination in Africa. And since that time, we have been working with partners, to ensure that we bring all relevant stakeholders on board to heed the call to action from our head of state and government, to accelerate the COVID-19 vaccination on the continent of Africa. Now, we've put together a couple of activities under our Saving Life and Livelihood program, which we believe will assist us to get to that 70%. And first on the list there is to ensure that the supply of these vaccines is properly coordinated. Some few weeks ago, John did mention something in that regard, that we are seeing a lot of vaccines coming to the continent, but in a very uncoordinated manner. And when you do that, you are going to clog or block the system. And we have seen that happening in Kenya just 1 or 2 weeks ago, whereby it's around 40,000 doses of COVID-19 vaccine has avoidably expired. This they actually show us, just a lack of coordination, So we call for supplies of vaccine, but properly coordinated. And in addition to the supply of vaccines, we also want to see that those vaccines that are coming, especially through the bilateral mechanism, need to come with the vaccine ancillaries, or we make provision for that. Because it's of no use for vaccine doses to come and there are no ancillaries. So there is no way you can scale up vaccination by so doing. Number 2 is logistics. So we have to find a way to support last mile delivery. It's not enough to bring those vaccines and put them at the national warehouse at our capitals. We have to find a way to ensure that this gets to the last mile, those nook and corners, those are to reach areas, so that at the end of the day, we can say that we have adequate population coverage as far as this COVID-19 vaccine is concerned. Number 3 is risk communication and community engagement. Tom Frieden has unpacked this, but let me just say that this is key if at all we are going to scale up COVID-19 vaccination in Africa. We need to have a very strong risk communication and community engagement strategy, because that's the only way we can create demand for those vaccines that are coming in. One of the things we are seeing from different surveys that we have conducted on the continent of Africa, including the one that was cited by Tom Frieden, that's the one that was conducted by partners, PEC. Before that, the Africa CDC, together with London School of Hygiene and Tropical Medicine, did conduct one survey, and just of recent, we just finalized one as well. So one clear thing that is coming out of there is that a lot of the people who are hesitant as far as vaccines on the continent of Africa is concerned actually need more information. They are not necessarily anti-vaxxers. So you just have to find a way of properly communicating, what this vaccine is all about to them. Very critical, the message and the messenger. So risk communication and community engagement is one key thing that we as Africa CDC continue to prioritize to create demand for this COVID-19 vaccine. We need to engage the different community influencers, the church leaders, the traditional rulers, our sportsmen, our artists, and just of recent, we launched what we call the AU, that's African Union Bingwas Initiative, which is targeting the youth. As you are all aware, more than 65% of our population in Africa are actually below 25 years of age. So without strategically engaging them, there is no way we can increase vaccine uptake. So we have launched this initiative. Our youth are fully on board. We have engaged those musicians, and we are calling on all partners to support us. We believe that with this, we'll be able to move that needle from that 15% that we currently have to something close to 70% before the year comes to an end. We are also calling on support for COVID-19 vaccination centers, especially mobile services. Without mobile services, there is no way we can reach that 70%. So this is one thing that we want to see a lot of support going into that. And in addition to setting up those CVCs or COVID-19 vaccination centers, we need to provide the needed such capacity so that we do not undermine the routine immunization. So we need to find a way to support that. And when we do that, we believe we'll be able to scale up these vaccinations. The Africa CDC is also prioritizing monitoring of adverse events following immunization. Because one thing we are seeing that is driving hesitant or vaccine hesitant in some corner of Africa is the so-called side effect, So we need to find a way to put in place a very strong pharmacovigilance so that we're able to pick up some of these side effects, address them, manage them, and couple that with appropriate communication to the public, so as to increase their confidence in these vaccines. Pathogen genomic sequencing is also very important because we need to know which variant is circulating and which vaccine, is best for that, and demonstrate, come up with that evidence, generate those data from our continent. With this, we believe we also increase the confidence of our population in the vaccines. Data and information system, very important. Tom Frieden talked about this. For point of emphasis, again, we want to see this prioritized, and we believe that if you prioritize this, you're able to use data, you're able to use evidence to inform whatever strategy that is deployed, to accelerate this COVID-19 vaccines on the continent. Technical support to our member state is also key. Let me also emphasize here that we continue to push for one country, one plan. And underneath this is about coordination. It's about collaboration. It's about allowing our member states to take the lead, to take ownership, and drive whatever agenda that is put in place. In a situation whereby we relegate the member state to the background and just, dictate to them what they should do, at the long run, it doesn't work. So we want to see our member state take proper ownership of whatever implementation plan that is put in place to address or to scale up this COVID-19 vaccination. The last but not the least, political support. This is key. We have seen that in Morocco, whereby when the king came out, to tell the people that please go and get vaccinated. And today I'm taking my own shot. We saw the way Morocco rapidly moved from 30% to something close to 70%. And as Africa CDC, we were there. We saw the role that had been played by the royal family in terms of the vaccination. And we're also able to talk to some governors, in the different regions, about 5 regions of Morocco. You could see the governors taking the leadership as far as mobilizing people to go and get their shot is concerned. Political leadership is key. And if there is anything that is behind the success story of Africa CDC, I think it's that political leadership. We have been able to brief or talk to our head of state and government more than 18 times since this COVID-19 pandemic started. and we have been able to use that to enlist their support. So they are actually been at the forefront of the COVID-19 vaccine or vaccination on the continent of Africa. So to conclude, I think for Africa CDC, we continue to emphasize the need for one country, one plan. Proper coordination, collaboration, partnership. That is the only way we can move the needle from 15% that we currently have on the continent to 70% as seen elsewhere in the world. Over to you, Chair.
Thank you very much, Dr. Tajudeen, and I look forward to your participation in the discussion. The last commenter that I want to introduce is actually one of our conveners, Dr. Wilmot James, who is a senior research scholar at the Institute for Social and Economic Research and Policy at Columbia, and was a member of parliament and opposition spokesman on health in South Africa. He's a sociologist by training and a policy specialist, and his research interests include global health security, particularly the welfare of children. And I wanted Dr. James to make a few comments on his thoughts about how government gets involved and helps present this message that Dr. Tajudeen talked about. He talked about how you do this by example, but when you're in the government, how do you formulate this and make the policy actually work? Thank you, Dr. James.
Thank you very much, Phil, and thank you to all the previous speakers who gave such an excellent outline of the issues. So a number of the speakers already hinted at the role of politicians and also the role of civil servants, particularly public health experts, in communicating and setting an example and communicating the right messages in order to achieve a range of credible public health goals. So I'd like to make two comments about that. The first is focusing on politicians. There's a big distinction to be made between a politician who is elected by a constituency and a public health expert who's appointed as a civil servant. You get the politicians you get, the civil servants you appoint against criteria. And usually those criteria are rigorously managed. So you don't appoint a public health expert without qualifications in public health. The really good example I like to use is that you don't have a pilot fly a plane unless they are expert at it and they're deeply experienced, and there are rigorous systems for recruiting pilots. So when you get onto a plane, you trust that that pilot will fly the plane properly. And there's no doubt about it normally, and millions of people get onto planes. Politicians get elected, they are not appointed, and you really get what you get. And therefore, we need to understand that the interest of politicians in achieving public health goals is something that has to be placed within what it is their interests are. So to say, first of all, that what politicians are after as a matter of their business, they're after votes. And so I used to be in a political party in South Africa where and this happens in a system where there's proportional representation and the party has an interest in recruiting the right people, that we had something called a candidate selection process. And we would look for three things. We would look for whether that person has the ability. We'd screen out all the bad things, right? Criminal record and so on. But the good things we're looking for are what? Ability to attract votes, is their magnetism, which also has to do with the ability to communicate with the public, their ability to make laws, they're lawmakers. We don't recruit all politicians to do that, but most of them would have to do that. And their ability to look after their constituencies. That is what you look for. And we need to understand that, that in order to get a politician involved in this business, you must be able to set things up in such a way that it meets some of their goals. So, but to say you get the politicians, you get some people are very good communicators. I think of the Prime Minister of New Zealand, for example, on COVID-19. She's absolutely excellent. And she's sincere and so on. She's very good. And then we have terrible communicators. I mean, the worst example, in fact, was Donald Trump. But there are sitting presidents right now, terrible communicators and setting bad examples. So, so that's the one point. The second point I want to make is that because politicians are what they are, they always get involved in the response to a pandemic or a crisis. They have no interest in paying any attention to prevention. And that is, without being cynical about it, when there's a crisis and it affects the community and it's massive damage to a community, politicians are there, they're responding, they mobilize resources and so on to help. And it's seen, it's visible. So the media is attracted, the media is actually deliberately brought there, and the politicians visibly respond to that community. Why? Some of them because they're sincere, but many of them is because it's a great opportunity to actually attract more votes. So, which is a very cynical reading, but that's the nature of the business. It's very difficult to get politicians involved in prevention, to invest in prevention, for example, because if you prevent a crisis, nothing happens. There is no response. There are no photo opportunities, and there's nobody that gets thanked along the way. So you have to work much harder at that. So let me just say that as a former politician, that what you require is a strategy that elevates your public health expert to deliver the message, and it has to be consistently given by that same person. We've seen it in the case of Anthony Fauci, trusted, sincere, evidence-based communicator on the public health side. He's clearly very skilled. He's been selected to do that. So, and that's the important thing, first of all, I want to make. South Africa had an excellent communicator in the name of Slim Karim, who is a great public health expert. He's very similar to Tony Fauci, and he carried that message. He is no longer that, and I'm not sure quite why, but he's a great message. On the political side, you get what you get. You get a Donald Trump or a Bolsonaro from Brazil, but you also get a Jacinda Ardern, and a range of other politicians have been very good. So the third point that I want to make, I was going to make 2 points, but there is a third one, is about bipartisanship. So every political party is in the business of offering the best policy options to their voters. And those are about ideas. And it's a war, it's a competition. Whose idea is better than somebody else's idea? So we need to understand that. But every political party also has the responsibility of deciding what is partisan and what's not. That is, what's in the national interest, and with a pandemic, what's in the global interest, and actually make a decision about that as a party and say that this is in the national interest. Containing an epidemic, containing a pandemic is in the national interest, and we will cooperate with other political parties and government in bringing our part to that. So that's a responsible decision that a political party takes. Not all political parties do that, but the responsible political parties will do that, because you have to have a commitment to serving the national interest too, when it comes to defense, when it comes to foreign affairs, and when it comes to things like epidemics and pandemics and public health. And on that basis, you act. That's how you support legislation. That's how you deal with your constituencies. That's how you run your campaigns. That is how you communicate. And there are political parties that simply don't do that. And I think one tragic example is the United States, where there is, in fact, no distinction being drawn. And I would say in the Republican Party, between what is of partisan interest and what is in the national interest and what is in the global interest. And I myself would just call upon parties, in fact, to rise to the occasion and begin to tackle that. So in response to your question, you can see, Phil, I have a lot to say about the subject and more. But if I can just articulate the need for making sure that there's an alignment increasingly between political leaders and their role, political parties and their role in dealing with pandemics. That alignment does not exist. It happen chance. We have control over some of that, and we don't control over a lot of that. So for that.
Thank you, Wilmot. And I'm sure we'll come back to some of these issues during the discussion. So the first question I want to pose to the panel is this issue of, you've all talked about the importance of crafting a message and getting the message right. But as we've seen many times in this epidemic, the science is changing as we go along. We're learning many things about the virus. We're learning a lot about the immune response, and we're certainly learning what the vaccines can and can't do. And I guess the question, we'll start with Dr. Frieden. Once you craft a message, how do you build into that message the trustworthiness and the frankness that you talked about, that things are going to change as time goes on, and we might have to retool what I told you a couple months ago?
I think first off, it partly depends on how you frame things. So at the outset, you should almost always preface what you say with based on what we know now. Mm-hmm. And this might change. So you're giving what pediatricians sometimes call anticipatory guidance. You're signaling that, listen, this is what we know now. If the facts change, we'll let you know. And it gets to a much broader risk communication principle, which is that constantly we should be letting people know what we know when we know it, how we know it, what we don't know, and what we're doing to try to find it out. That's a way to build trust. What I've found in some of the focus groups that were done by with people with a lot of vaccine hesitancy in the US, people had a lot of questions, and they were quite valid questions, and they just didn't feel respected. They didn't feel like their questions were being listened to. They felt they were being demonized. They felt quite alienated from the mainstream media. But in a couple of hour session, you could get a real sense of, all right, here are the facts. Here's what we know. Here's what we don't know. So I think that a lot of times when people think about communication, you think, oh, you have to be very definitive. Well, there's, I don't know if you're familiar with the work of Peter Sandman. Peter Sandman is really a superb risk communicator. He's largely retired now, though he continues to comment quite a bit on things. And he has what is referred to as the Sandman seesaw. And the point he makes is, the more certain you are in one direction, you're pushing the audience to be uncertain in that same direction, and vice versa. So in contrast to kind of our gut reaction might be, all right, let's just say very clearly that this is definitely the case, because that'll convince people. That's actually not the case. What will convince people most is if you take them into your reasoning process. You explain how you know something, what you think of it. You're clear that this is what the data shows. Now, I'll use a current example. Today, the FDA just authorized a fourth booster for people ages 50 and over, 4 months after their third booster, based on very partial data that there is a waning of immunity, and likely that CDC will say, if you want one, you're going to have one, not we're recommending you get one, because there is, to use a fancy term, there's equipoise. In other words, maybe yes, maybe no, in a more simple way of communicating, that we don't really know how much benefit there will be to a fourth dose and for whom. But it's respecting the public to make clear, here's what we know, here's what we don't. You're adults, here's the decision that you can make. That's actually more convincing than saying, you should do it this way, because insisting on something creates kind of a pushback. So I think it's extremely important from the outset to be clear about what we don't know, that we're making the decision based on what we know now, and it might change. Now, there are two big caveats to that. One, people who have not had a lot of formal education may be more inclined to say, just tell me what the story is. If you're not sure, then you don't know what you're talking about. And so, yes, you will lose some people from that. In fact, some of these focus groups that I'm referring to, they said, I just want to know, one thing and it shouldn't change. Well, reality changes. And that's why we change our recommendations. The second is, for that to be effective, you have to communicate regularly. And as Wilmot was saying, to have one person speaking or one organization speaking over and over again is very important. And that's why I think it's been so unfortunate that you haven't had the US CDC out there. But when I was director, I briefed daily on Zika, on Ebola, on H1N1, and every day or almost every day. And we got things wrong because that's the way science worked. But it allowed us to have kind of a conversation with people. And it's not only the public, it's also the reporters, because reporters will ask a series of questions that force you to up your game, that force you to be more clear about what you said, why you said it, whether it's clear. There are a lot of times when we think we've been really clear, and then a really smart science reporter will ask a question. I say, wow, we thought we explained it clearly, but if the science reporter didn't understand it, what possible hope do we have of the public understanding it, because we weren't nearly as clear as we thought we had been?
Thanks. Dan, and then Raji, do you want to make comments?
No, I mean, it was so well put. I remember decades ago being at CDC in a very junior position and being handed a training on how to talk to the public and to the media during an outbreak. And it's exactly as described. This is what we know. This is what we don't know. This is what we're doing to figure out what we don't know. And this is what you should do for now. And that approach, we did also a lot of focus groups, and people kept bringing up the mask. First you said, wear a mask, then you said, don't wear a mask. And when we explained why the recommendations changed and how they changed, and ultimately we created animation around that, explaining to people that, yes, recommendations change as knowledge grows. And it's that responsiveness, which is what science and public health should be doing. So if you get that right from the beginning and do it in an ongoing way, you will build credibility. But when you overspeak and then have to change recommendations that people don't understand, that's where so yeah, they're really important points.
Raji, did you want to make some comments?
Yeah, no, thank you, Philip. I think just to complement what the two previous speakers have said, I think for me, one, the messenger is as important as the message. Mm-hmm. So we need to identify who are the trusted voices in the community. And Africa CDC, we've been able to make use of this a lot, because some of what we are seeing from our perception survey is that some voices are actually much more well respected in the community than others. Healthcare workers, traditional rulers, in some places, politicians, in some other places, don't even bring politicians into the whole equation. So trusted voices in the community, very important. Number two, the content of that message should be locally contextualized. We know that in Africa, there are regards and respect for certain things, and culture vary from one community to the other. So as much as possible, we need to locally contextualize our message. And this is where the role of our behavioral scientists, the role of our medical anthropologists is key in getting some of these messages across to the community. Number three, as much as possible, our messages should be evidence-informed, and when those evidence also change, as Tom Frieden has mentioned, we should not be shy away from informing the community. After all, the pandemic itself is still evolving, quite dynamic. Thank you, and over to you, Philip.
Thank you. Wilmot, I have a question for you. So here now the scientists are saying, hey, by the way, we've looked at some new data and we need to make a new recommendation. As a politician, and somebody who's in some way going to express that message to the public. How do you handle that?
Well, given where we are with the pandemic, it's very clear that localized or locally based information about where the pandemic is and what needs to be done is becoming increasingly important. So people in particular neighborhoods would like to know what's happening next door in the next neighborhood in New York. They're not particularly interested in what's going on in Johannesburg. And what that implies is that your risk communication, and I'm building on the points made by Raji and Tom, that risk communication has to be a local matter. That means if you need local information, so it's a community-based epidemiology, you need to find influences that have local credibility, and you need to identify that in a kind of rigorous basis. And you need to empower and help your local councillors and your local politicians to actually articulate the risk communication messages. That is the translation exercise that needs to be done. And all countries must empower communities to do that, provide them with the tools to do that. It costs money. To have locally based surveys is a question of budgets. And then you need a research operation that allows you to identify what the barriers are to access to vaccination sites on a local basis. You need research to identify who the influencers are, because they vary culturally. And those examples already mentioned. In some countries, it's a sports personality or an entertainment personality. In other words, a priest or an imam. In other places, it's, let me say it's rarely a politician. But your politicians are important because they allocate budgets. So you need to cultivate that. So what you require is to translate science into political action. And there you need to engage your politicians. So one of the lessons we've learned is that there has to be active public engagement when it comes to dealing with public representatives. And you must be able to provide politicians, you have to package the information so politicians can absorb it. They don't want to absorb complex science. What they want to absorb are the basic, simple messages. And they would need to know how to structure that in a series of statements that's used as a basis to communicate risk. So I'm giving you somewhat of a long-winded answer to your question, which is to say that it's all about local. And as COVID-19 becomes more and more endemic and outbreaks are actually far more localized as we head into the future, it's really important to empower local communities and engage with politicians on a local level together with that kind of team that's required.
Thank you, Wilmot. The other issue I would like you all to address, and you've done this in some of your presentations, is what I find is the particularly thorny issue of hesitancy among healthcare workers. This is a group of people who have borne the brunt of caring for COVID patients and assumed a lot of the risk of caring for those patients under extremely difficult situations in many cases. And I get the feeling that we could do a better job of crafting the question of risk of vaccines and also the efficacy of vaccines to these healthcare workers. And I don't know if, why don't we start with Tom and then Dan and Raji, see if you want to make any comments specifically about helping healthcare workers address these issues.
Well, I think as I mentioned in the presentation, the first is to get healthcare workers vaccinated. So have them address what their concerns are. We did with a group in Sierra Leone, we did outreach to 8,000 healthcare workers. They did outreach that we supported, and 97% took the vaccine. Mm-hmm. So you can get very, very high levels of vaccine uptake when you do outreach. And then health workers really need better protections in so many ways. There was a lot of focus, appropriately so, on the lack of personal protective equipment during the pandemic. But PPE is only one of the many lines of defense that are necessary to protect healthcare workers from infection, let alone other things as well. I mean, we're seeing horrific attacks on healthcare facilities in Ukraine and also globally for the past many years. There's been kind of a movement away from the respect for healthcare as a neutral entity. So you see violence in healthcare facilities, or you see very basic things, the lack of running water in more than a third of healthcare facilities in Africa. How are people supposed to wash their hands with no running water? And this is something that has to be addressed. There are also administrative policies that can greatly reduce the risk to healthcare workers, whether that's patient flow or televisits. So I think healthcare workers need to be empowered. There's also emerging evidence that's pretty intuitively obvious as well, that one of the challenges in getting healthcare workers to manage and care for patients respectfully is that healthcare workers aren't treated respectfully by their healthcare systems. Mm-hmm. They're not paid adequately. They're not given sufficient job security. They don't have appropriate equipment to keep them safe. They don't sometimes have the training they need to do the jobs they're being asked to do. They don't have the support they need to address some of the mental health challenges they're dealing with. And we're seeing very serious mental health problems among providers who have dealt with horrific situations for the past 2 years. So I think strengthening the hands of healthcare workers means supporting healthcare workers much more effectively so that they have the tools and the safety to do their jobs, as well as continuing to upgrade their skills and capacities.
Thank you, Tom. Dan, did you want to make some comments?
Yeah, I mean, we've done a few surveys of healthcare workers around COVID and through different methods. And, you know, what we found is that when you look at the doctors and physicians, they're really supportive of COVID vaccines, and uptake is super high. And as you look at different types of healthcare workers, when you look at nurses, they look a lot like the general public in terms of what concerns they have and how frequent those concerns, the prevalence, as well as vaccine acceptance. So I would say don't look at them as a single group, because they're not, and they vary tremendously in lots of ways, both in terms of training, but also they tend to reflect their local communities, and they come to that job with all of the values and underlying world history of that community. I think we need to look at the education and training. You know, what are we teaching in the clinical training to make sure that across the board they have the knowledge of not just how vaccines work, but also how to communicate with patients, because how you talk about vaccines really matters. And there's really good evidence on what approaches work and which don't. We're about to launch a CME module that teaches clinicians on how to talk to patients. But underneath, they need to have the knowledge, the confidence themselves. If you have a nurse who isn't vaccinated because she's worried about how fast the vaccines were developed, there's a pretty good chance that she's probably not, or he's probably not the best person to advocate for vaccination among the patients. And we saw this with flu too, right? Flu vaccine. You know, most places don't get really high coverage across the board absent mandates. They get pretty good coverage, maybe 70%, maybe 80% through access and education. And you know, I guess if you're a cup half full kind of person, that's more than half full, but it's certainly not where it needs to be.
Yeah. Well, you know, I go back, I like that slide that Tom showed about lessons that we should have learned. And it seems to me that we've taken a lot for granted and not addressed the needs of healthcare workers when it was obvious that was something we probably should have done very early on. Raji, did you want to make additional comments?
You know, thank you, Philip. I think one, we need to understand that for most part of Africa and possibly elsewhere, our healthcare workers remain trusted voices when it comes to uptake of these vaccines. And now realizing that three key things for me. One, we need the healthcare workers to take the shots themselves. Two, we need them to serve as mobilizers, to mobilize others to come and take the shot. Three, we need them to provide safe services. Now, for them to be able to carry out these three key functions, we need to educate them, as Daniel has rightly mentioned, because in the absence of education, there's no way they can convince other people, to take up these shots. We need to build their capacity to be able to do so, and we need to protect them. And of course, adequate incentive is also key if we really want them to deliver these services and the scale of this COVID-19 vaccination. Thank you. Over to you, Philip.
Thank you. The last question I'd like to pose to you all is the changing face of the epidemic, where it seems like we're going into a more of an endemic chronic situation. And I worry about COVID vaccine fatigue and disinterest, much the way we had at certain points during the polio eradication effort. And I wonder if any of you have comments that you want to make about needs for changing in how we message this as the problem continues over a longer period of time than any of us would have wished for.
Maybe I can make one brief comment. I think this is, to me, there are three major lessons from the pandemic. The first is a need for a public health renaissance. The second is the need to make primary health care the center of our healthcare systems. And the third is for more resilient populations. We've talked some about a public health renaissance. That means better surveillance, better community engagement, better communications, better outreach programs, better management of programs. Primary health care is so neglected in so many countries, certainly including the United States. It's more of an afterthought than a center of our healthcare system. And it's one of the reasons it's very hard to manage COVID. I recall a few years ago when I was health commissioner, we were doing some big campaigns on preventive healthcare, one for flu, one for pap smears. And one of our staff had lived in Sweden. And she said, when I lived in Sweden, I just got a note from my primary care doctor, time to come in for my vaccine. And I went in. We get that for our, many of us, for our pets. We get it for our car when it's time for an oil change or for our dental work. We don't get it for our healthcare because we don't have a primary healthcare system. And the resilient population issue is quite important. It's not just about COVID, but generally with out of control diabetes, with smoking, lung disease, cancer, other problems, many of which are preventable. We really could do much better to have a society that's much more able to withstand an infectious disease shock if we have a resilient population, a robust primary healthcare system, and a really newly effective public health program. So I don't think there's any way to keep people's attention on COVID except the people who want to keep and do keep their attention. There are just most of the country, most of the world has moved on, even though the virus hasn't. And that means we need to adapt our messaging and adapt our outreach techniques.
Thank you. Dan?
I think, absent another terrible strain, we need to wrap it into routine vaccination and as a standalone and, as much as possible into routine vaccination. I think the problem we have, and you mentioned polio, Phil, people are worried about what they're worried about. So if you go into a community that has huge problems and you're talking about a disease which is very important to you, but not to that population, it doesn't feel right. It doesn't seem right. And it's going to really be a challenge. I mean, that's what we find ourselves in with polio, where fortunately, because of vaccines, they no longer impact huge numbers of people and people aren't afraid of polio. And the perception of the severity of COVID depends a lot on other risks that you experience. I think we have to transition making COVID a routine vaccine and integrate it into primary care and into public health.
Thank you. Raji?
Yeah, no, thank you, Philip. I think we've seen some of this happening, especially in Africa. There's no doubt about it. I mean, people have lowered their guards, but going forward, I think I agree with Dan and Tom. We need to integrate the COVID-19 vaccination into our existing programs, and some member states have started doing that, especially Nigeria. And the number two thing we need to do is to put in place a very smart surveillance system, so that we'll be able to pick whatever variant that is coming out or whatever, and where those variants are circulating. So meaning that our molecular surveillance by way of pathogen genomic sequencing also need to be very strong. Over to you, Philip.
Thank you. Wilmot, do you want to make any final comments as from the political point of view about the endemicity of COVID?
Well, simply to say that in order to achieve everything has been recommended now by my colleagues on this panel, what you need is to change the incentive architecture that exists, which is a fancy way of saying that government should spend more on this area. Government should spend more on primary healthcare systems. I completely agree. You have to put funding behind it. Funding is not the only problem, I know that, but to really get things going, there's a need for governments to commit more to this. There's a need for African governments to commit more to this globally. So that's the one comment I would want to make, and that doesn't happen automatically. It requires advocacy, but we need to work with politicians to get the budgets in place. Without the budgets behind the plan, very little is going to happen. So it happen on a sustained basis, not when there's a crisis. It has to be sustained. The second point is we have to remember on the reflection that we are risk communicating in a particular context. Some countries are at peace, other countries are at war. We presently are looking at what's happening in Ukraine, and how do you risk communicate in the middle of a war on a public health issue? How do you look after your health workers in the middle of a war? So we're looking at Ukraine, but also there's been an ongoing a war in Ethiopia and other parts of Africa as well. And the question is, how do you deal with those complex crisis situations when you need to deal with a public health crisis in the middle of great instability? And so a strategy is needed to do that. And how do you look after your healthcare workers in the midst of that?
Thank you. Well, I just wanted to make a few closing comments. First, I want to thank the presenters for their thoughtful presentations. I've learned a lot. I like Tom's statement that trust can't be surged, and Dan talking about the importance of how you present risk, and Raji talking about how it's important to find the right people to present the message to the population, and how we're going to have to do this on a continual basis as we go on. And Wilmot talking about the importance of political support, and most importantly, financial support that the government provides in order to enact these programs as we move into a more primary care public health approach to COVID as an ongoing problem. So I want to thank you all, and I hope that you come listen in. Tomorrow's session is vaccine equity and distribution, capacity building in terms of intellectual property, tech, and talent transfer and manufacturing. So now I'll turn this back to Jill Wick, and thank you again.
Hi. Thank you, Dr. LaRussa. I'm Jill Wick, Director of Digital Strategy and Marketing here at Columbia University Irving Medical Center in New York City. I also want to echo thank you to our speakers for joining us today and addressing such critical ongoing issues. It was a really wonderful session. We want to extend our gratitude to the Grodman Family Foundation and Pfizer for making the symposium possible. Thank you to our external partners, the Rhodes Trust, the Atlantic Trust, and the Schmidt Science Fellows, and our internal partners, the Vaccine Safety and Confidence Building Working Group, VacSafe, the Institute for Social and Economic Research and Policy, ISERP, and the entire Columbia University community. So like Dr. LaRussa said, join us again tomorrow at noon Eastern time here on Zoom, live on social media. It's going to be another great symposium day. So thank you, everybody.